Welcome to the ICMR NVCCP Prescribing Skills course for the Indian medical graduate. I'm Dr. Ritika Malik Yadav, a clinical scientist from ICMR NIIH, and I'll be talking to you about transfusion reactions, approach to G6PD deficiency, and thrombocytopenia. At the end of this module, please answer the MCQ questions which are provided in the assignment section. The outline of the presentation will include the patient presentation and approach, do's and don'ts, and take-home messages. At the end of this module, the Indian medical graduate should be able to understand the clinical approach to bleeding manifestations and order appropriate investigations, know the management of these disorders needed at the primary healthcare level and referral criteria, be aware of imparting genetic counseling to such families and availability of prenatal diagnosis, and outline the steps of a safe blood transfusion. So let's begin first with transfusion reactions. A transfusion reaction can be defined as an unintended response in a patient to transfusion of blood components which prolongs hospitalization, is disabling or incapacitating, and increases morbidity or causes mortality. Transfusion reactions can be broadly classified as acute or delayed depending upon the time of occurrence within 24 hours or later, and immune or non-immune depending upon the pathophysiology. You may refer to the handout for common types of transfusion reactions and their management in detail. Here in this presentation, I'll be taking you through the common transfusion reactions and their management. So we will first discuss in some detail the acute hemolytic transfusion reaction, which may be suspected, as you can see in this cartoon, when a patient experiences fever with chills, hypotension or tachycardia, cola-colored urine in the urine bag, or complaints of nausea, vomiting, or pain in the flanks, back, abdomen, or chest after starting a transfusion. In case any of these occurs, immediately stop the transfusion and keep the IV line open with normal saline and give injection furosemide. Institute immediate resuscitative care and give the patient corticosteroids if required. You will need to send to the blood bank, the blood bag and the transfusion set, a post-transfusion blood sample of 3 to 4 ml in EDTA vial, and the reaction form with details of the nature of the reaction. Now coming over to the most common transfusion reactions, which are the febrile non-hemolytic transfusion reactions. The symptoms of these can be fever with chills and rigors, cold, headache, nausea and vomiting. And the management will comprise of a tablet paracetamol, which may be given if this reaction occurs repeatedly in the form of a pre-medication of antipyretic. However, a cautionary note is that the antipyretic may mask the signs and symptoms of other more serious transfusion reactions, so vigilance becomes all the more important. To prevent these reactions, the patient should receive leukodepleted packed red blood cells of less than 14 days duration if possible. Now some general do's and don'ts to prevent transfusion reactions are as follows. Always recheck the information and always recheck the blood group prior to transfusion. Visual inspection of the blood components prior to issue and prior to transfusion for bloating, discoloration, floaters, hemolysis and leakage is essential. Obtain the patient's transfusion history and note any allergies in previous transfusions. Start the transfusion of blood within 30 minutes of receipt from the blood bank and maintain a cold chain. If you feel that there has been a breach in the cold chain, the blood component should not be transfused and should be sent back to the blood bank. Complete the transfusion within 3 to 4 hours. There is no need to warm the blood before transfusing under blankets or under tap water, etc. And as far as possible, patient should receive leukodepleted PRBCs of less than 14 days duration. Most transfusion reactions occur within the first 15 minutes of starting a transfusion. Therefore, infusing small amounts of a blood component initially minimizes the volume of blood to which the patient is exposed, thereby minimizing the severity of the reaction. And it's very important to monitor the patient's vital signs, especially within the first few minutes of a transfusion. In case of volume overload and cardiac failure, slow transfusion is preferred and you may give injection Lasix. No other infusions are to be administered through the same IV site as the blood transfusion. To prevent transfusion-transmitted diseases, check HBsAg, HCV and HIV status every 6 months, and NAT tested blood is preferable. Now coming over to the next topic for this presentation, G6PD deficiency. I'll be taking it in short. It is the most common X-linked genetic disorder. In India, its prevalence varies from 2% to 27%, with an overall prevalence of 7.7% in different tribal groups of Western and Central India, Odisha, West Bengal, Nagaland and Dadra and Nagar Haveli. Why we need to study this is that the most commonly used chloroquine-based antimalarials can cause hemolysis and G6PD deficiency. Hence, testing should be done before initiating antimalarials in fever. Neonates should be tested for G6PD deficiency if they have a family history of hemolysis, or they are from high endemic regions, or if there is persistence of neonatal jaundice. In case of adults with acute or chronic hemolytic anemia after exposure to drugs, stress or fever, do check for G6PD deficiency. Screening for G6PD can be done by demonstration of decreased enzyme activity of less than 30% of normal by the dichlorophenol indophenol decolorization method, and the confirmation can be done by quantitative estimation of G6PD activity at a higher center. Please note that during an acute attack, the report may be normal due to reticulocytosis, so the test may need to be repeated after the acute attack settles. The management of an acute attack would comprise of supportive care, avoidance of further triggers, and in case of severe hemolysis, blood transfusion and hemodialysis may be needed. You may refer to details about G6PD provided in the handout. What I would like to focus more on is that drugs with a definite risk of hemolysis should be avoided in these patients. These drugs with a definite risk of hemolysis will include primaquine, nitrofurantoins, quinolones, chloramphenicol, sulfonamides. It would be advisable to conduct a G6PD screening test in case of fever in high-risk areas before initiating these drugs. Other drugs with a possible risk of hemolysis include aspirin, paracetamol, phenytoin, chloroquine, proguanil, pyrimethamine and isoniazid. A detailed list of drugs to be avoided is available in the handout. It is also suggested that if a patient is diagnosed with G6PD deficiency, a list of cautionable drugs may be made available with the patient. Next, we come over to thrombocytopenia. Thrombocytopenia is defined as a platelet count of less than 1.5 lakhs per microliter. Pseudothrombocytopenia, a falsely low platelet count, can be caused by in vitro agglutination of platelets in EDTA tubes and needs to be ruled out by examining the peripheral smear. A recent drop in platelet count by half, even within the normal range, may herald a severe clinical problem and should be investigated. Thrombocytopenia as such can be isolated, can be as a part of a spectrum of pancytopenia or a part of a multisystem involvement. Potential risk of life-threatening bleed occurs with a platelet count of 10 to 20,000 per microliter and a risk of spontaneous intracranial bleed with a count of less than 10,000 per microliter. Causes of thrombocytopenia include viral infections like dengue, rubella, mumps, HIV, HCV, varicella, etc., marrow failure syndromes, immune thrombocytopenia, and drug-induced thrombocytopenia. So the important points in history will include a history of recent infection, history of recent vaccinations, medication history with drugs like aspirin, NSAIDs, heparin or warfarin, history of recent transfusion, significant family history, presence of gynecological problems like menorrhagia, and history of liver or renal dysfunction. Important points in examination will include the type of bleeding, whether superficial, deep or presence of joint bleed, whether the bleeding is spontaneous or traumatic, and general physical examination for jaundice, hepatosplenomegaly and lymphadenopathy. The additional investigations that you will need will comprise of a complete blood count, peripheral smear, ESR, reticulocyte count. Further tests would depend upon the history and may include an infection workup, liver and kidney function tests, coagulation profile, bone marrow examination, and antibodies to platelets. Further interpretation of investigations and course of illness may give a clue to the diagnosis, and for additional reading, you may refer to the handout. The management of thrombocytopenia is primarily directed at the underlying disorder. One of the commonest causes of thrombocytopenia being dengue, certain important points to note would be taking bed rest, drinking plenty of water to avoid dehydration, avoiding drugs which can cause bleeding. So mostly paracetamol is given for fever and not the other NSAIDs, and monitoring of platelet count at hematocrit. Drugs causing thrombocytopenia should be avoided in all cases. A therapeutic platelet transfusion is given in a patient with thrombocytopenia if there is risk of life-threatening bleed, for example in case of intracranial hemorrhage, hematemesis or melena, severe menorrhagia or emergency surgery. Platelet transfusions are considered inappropriate in ITP as the survival of transfused platelets is very brief, as short as few minutes. It is also contraindicated in heparin-induced thrombocytopenia and thrombotic thrombocytopenic purpura. However, in a case of ITP with an intracranial bleed, platelets may be transfused. While we are talking of bleeding, I would like to mention that coagulation defect should be suspected in patients presenting with easy bruising in early childhood, excessive bleeding following trauma, surgery, dental extraction, recurrent bleed or menorrhagia, a positive family history. Vitamin K deficiency can also cause severe bleeding in newborns, so a history of vitamin K supplementation at birth becomes important. In case you suspect a bleeding disorder, the patient should be referred to a higher center for workup for bleeding disorders. Adjunctive management for a joint bleed at a primary healthcare level will comprise of what we call as the PRICE, where P stands for protection with splints or compression bandages, R stands for resting the part, I stands for ice application, where crushed ice wrapped in a towel may be applied around the joint for 10 to 20 minutes every 2 to 4 hours to relieve pain. I should not be applied in direct contact with the skin. C stands for compression and E stands for elevation of the joint. And avoid NSAIDs for pain. Paracetamol may be given. You might refer to additional reading material for more details on principles of management of coagulation disorders. So the take-home messages from the past few slides are: treat the patient and not the platelet count. In thrombocytopenic patients, the risk of life-threatening hemorrhage is approximately 1%. Risk of bleeding increases with concomitant secondary infections, disseminated intravascular coagulation, and drugs like NSAIDs. Platelet transfusions are not indicated for superficial bleeds, and a good dictum to follow in patients of thrombocytopenia is that if the patient is not bleeding, do not transfuse platelets. So these are the additional reading materials available with this module. You may care to go through them. I would like to acknowledge Dr. Farah Jejana, consultant clinical hematologist and hematoncologist from Hinduja Hospital, for reviewing this module. Dr. Anand Badade, project scientist, for helping in preparing the presentation and the handouts. These are a few references. Thank you for watching this video. I hope you are now ready for the MCQs. You will find them in the assignment section. Kindly answer them and upload the answers. Thank you and happy learning.